All right, so Katie, if you want to throw up the things, if Heather pops on, she can just get right into these. We have a lot of upcoming echoes. We have just filled up a ton of great talks. And actually, there's another one that's going to be on there. I was at a wedding in New York, north of New York City, and I ran into a psychotherapist who was in recovery, who was just excited to give a talk on our echoes. So we're going to have him as well. But a lot of great things. So next week, outpatient management of stimulant use disorder and cardiac consideration. So that's going to be a great talk. But I think we're basically full until October 18th, and we even have some stuff already in the following month. So lots of great talks. So keep coming back. Remember, there's free CME. And please, we have a lot of videos on today, so that's great. So please feel free to turn on your video, because Charlie loves to see who he's talking to. And he dressed up today. So I think it's important that we all turn on our videos to kind of recognize that. And remember, if you do need some technical assistance, please give us a call. You can see Aaron's name is on there as well. Unfortunately, way too many people have my cell phone number, but we always get some wonderful calls, some amazing cases that people come up with all over. So please feel free to give us a ring if you have some questions about a patient. We're always happy to help. Is Heather on here yet? No, I don't see her. And again, the Center for Opioid Resources and Education, which is online, has all of the stuff we've developed over the years, has some of the things for the echo if you want to watch an old one or see a picture of my dog from last week. All of that is on there. Next slide. Or not. And that's Charlie, but he's gonna share his thing. So everybody knows Charlie. He's an addiction medicine doctor down at Hennepin, and he's one of our favorite speakers. I believe Charlie has spoken 8 or 9 times on our echo. He is the leader in the number of talks he's given on our echo, and the most well attended. Actually, still has the record, I think, at right around 140 people the one time. So it goes way back. So thanks again, Charlie, for doing this for us.
But you blew that record out of the water when you did some of the COVID echoes. That was like blew the top off.
Yeah.
Okay. I'm going to share my slides, and there's always typical me. There's always a million things to. Let me see if I can. Yeah. Okay. A million things to talk about. Not enough time. So I'm going to try to just jump in, and if someone has a question, Kurt, you can interrupt me, or Heather when she gets on, it can interrupt me. But I'm going to just dive in. And tobacco is amazing. So you guys can hear me okay? Perfect. Tobacco is an amazing topic. Number one, because tobacco is one of the most researched things in the world. The studies on this are hundreds of thousands of patient years. Multiple giant studies. The Surgeon General's report on tobacco is 700 pages long, and there's probably 300 pages are just references. It's insane. The Surgeon General's report is where I got a lot of this information, and it's well organized, but it's an incredible resource. So I am going to not just talk about tobacco, but I'm going to try to use tobacco as a lens to understand addiction. And that includes public health, and that includes formation of addiction and how the pharmacology of nicotine causes an addiction. And then we're going to talk about special populations, including, adults, pediatric, surgical, obstetrical, psychiatric. I'm going to talk a little bit about e-cigarettes, and I'm going to also make sure you all are up to speed on how to help people quit smoking cigarettes. Let's see. Okay, so what I'm not going to do is try to convince you that tobacco is bad. I mean, this is not even a complete list of all the things that tobacco causes. It's like one of the most problematic things a person can do, probably the most problematic thing. And if you smoke a pack a day, you are 4 times more likely to die. Like your all-cause risk of death is 4 times higher if you smoke a pack of cigarettes a day. 500,000 Americans die a year from tobacco. That's more than 3 times alcohol and more than 5 times opioids. So it's huge. And not smoking Depends on what study you look at, but it adds 7.5 years to your life or 11 years to your life. It depends on the study, but it's ballpark 8 to 10 years to your life just not smoking. And the years are higher quality years if you're a non-smoker. So here is smoking prevalence per capita cigarettes used over the course of the decades. And so you can see that, you know, up until the 60s and 70s, there was a lot of tobacco use, and it has dramatically improved in America. So America has seen dramatic improvements in tobacco use rates. That is awesome. These are this include the white thing here is tobacco, but all these other things on top are other forms of tobacco, cigars, snuff, whatever. This does not include e-cigarettes because this is an old slide. So we're going to talk about e-cigarettes later. But if you put e-cigarettes on here, you'd see a very sharp increase. As everything else is trending down, e-cigarettes are going up in the last 10 years. So when there's something as terrible, you know, obviously terrible as tobacco, kills 500,000 people a year, and it's a behavioral aspect. I don't want to call it a choice, but it's a sort of a preventable death. It's a behavioral manifestation. How do you change behavior in a public health sense? And here's the recipe that the federal agencies and public health authorities are using to try to reduce tobacco. One is reduce the availability of tobacco. If it's not around as much, if it's harder to get, people won't use it. Two is reduce the social acceptability, and the ease of use. Make it shameful and hard to use it. Even if you have it, you're ashamed to use it. It's difficult to use it. You have to walk outside the restaurant on a cold winter Minnesota night and smoke in the cold. Number three, improve education about the health consequences of tobacco. Educate people. Sounds obvious, but that's step three. And step four, help people who are currently smoking, help them quit. That's the recipe. That's the recipe that the federal government and all the agencies have used to basically stem the tide of the tobacco epidemic. I mean, it's still terrible, but it was way worse previously. And I'm not going to go into this, but it is this constant, I'm going to give you an example of this in a few minutes, a constant back and forth with the tobacco industry. So the feds do one thing, the tobacco industry sues them, and then the feds countersue, and then the tobacco industry adjusts their product to meet a new regulation. I'm going to give you an example of this, but it is a constant back and forth between regulatory agencies and the tobacco industry, and e-cigarettes is the latest example of their way of sort of skirting around some of the regulations and messaging. So I think the most important thing that has ever been done to reduce the harms of tobacco is raising the price of cigarettes. It is the most important aspect of public health interventions on tobacco. So for example, if you raise the price of cigarettes by 10%, you will decrease cigarette consumption by up to 5%. So there is as the price goes up, use goes down. And if you increase the price of tobacco, just generally, you will reduce people from starting tobacco. Fewer people will start. Overall prevalence of use will go down. People who still use will use less. And people will want to quit more. So cost is the number 1, 2, 3. The top 10 interventions would all be raise the cost. Which is amazing to think about it. And here's a graph of the prevalence of tobacco use superimposed with the cost of cigarettes or a pack of cigarettes. And you can see as the cost goes up, use goes down. And I want to show this example. Look at the prevalence of cigars in 2010. So cigar use jumped in 2010. So why? What happened there? And this is a story about cost. And what happened in 2010 was that a new tax law was passed that said, okay, little cigars we're going to tax them like they're cigarettes. But big cigars, that's for like Steph Curry to smoke in the locker room after he wins his 10th NBA championship or whatever. That's for big cigars. It's for the fat cat in the C-suite at the penthouse office. You know, when they make the $1 million deal, they smoke their big cigars, right? So we're not worried about big cigars, right? So they made a new law saying big cigars don't have the same sort of taxing as everything else. Little cigars, snuff, all the rest. So right away, the tobacco industry read the fine print. How is big cigars defined? And they changed this product on the left, which is a little cigar, to this product on the right, which is technically by the letter of the law, as the federal agency defined it, a big cigar, but is basically still, it's not a big cigar. It's basically they just increased the size of their little cigars to meet the definition of big cigars and got a tax exemption. The price went down and the use went way up. So basically, if you give a tax break to cigars or cigarettes or tobacco, the use jumps. So it's just another example of how money rules the world. If there's one thing more powerful than tobacco, it might be money. And so then there's this question I was thinking about. You know, you heard about this term regressive. Are tobacco taxes regressive? Tobacco taxes affect poor people more than rich people. A billionaire doesn't care if you tax a cigarette. If a billionaire wants to smoke Marlboros, they don't care how much tax on it. They're going to go get a Marlboro, right? So billionaires are not sensitive to taxes, but poor people are very sensitive to taxes because they don't have, every little bit counts. So, and people talk about this with gas. When gas prices go up or you put a tax on gas, it is regressive. It punishes poor people because rich people will still drive. They don't care. But poor people, it affects them when their gas prices go up. So isn't this regressive? Aren't we punishing poor people with all these taxes? I mean, I would say no, because they're so tax sensitive that it hurts them more when the cost of cigarettes go up, and that's a good thing because they're going to quit more. They're more likely to quit because they feel the pain of that tax increase. So I actually don't think taxes are regressive in the case of tobacco. I do think they are in the case of gasoline. So I actually think taxes help poor people in the case of tobacco because tobacco is terrible, in my opinion. In addition to taxes, there are all these laws, and I mentioned earlier, if you're in a restaurant in the dead cold of January, winter, Minnesota, you got to go outside to smoke. And I'll explain some other reasons for that later in the talk, but part of it is just to ostracize and shame, and I'm just saying it bluntly, make it embarrassing to smoke cigarettes, make it inconvenient to smoke cigarettes. If you do that, if you create social stigma, those are those people under the heat lamp outside because they need to have their cigarettes, they're exposed, they're embarrassed. That reduces quit rates. That actually works to make people not want to smoke and want to quit if they do smoke. But as someone, my brother no longer smokes, but as someone with a brother who smokes cigarettes, he felt dehumanized by these laws. He was like, they treat me like dirt, you know, and some of these laws are intended to create stigma, literally intended to create stigma around tobacco. And it works. But should we be doing this? And that's an ethical question I'm not going to answer. When it's my brother who feels like he's being treated poorly by the city or state laws, I feel bad for him. But on the other hand, my brother did quit cigarettes, so I feel good for him. And another public health intervention is really important is honest information. And I was given this as a really good resource, including for adolescents. And this is kind of targeting adolescents to get them the information they need about nicotine and tobacco products. So good public health information is critical to motivate people to quit. I mean, hitting them in their wallet or pocketbook is worse, but information helps. And so here's a study where they every other week, they did a public health campaign on the radio, encouraging people to quit smoking and giving them a phone number for free quit smoking advice. And the blue bars are when they did the campaign versus when they didn't. And the black line is when that call line got calls. It's the 1-800-QUIT-NOW call line. It's just like the federal I want to quit smoking call line. And you can see that when they had the media campaign running, more people called and said, I want to quit. So public messaging does get them at least far enough to ask for help, which is a big deal. On the flip side, here is a really interesting graph. To me, it's interesting looking at depictions of tobacco use in movies. And the y-axis here is in-theater impressions. That means how many people are in the seat, in the theater, watching a movie. They paid money to go sit down and watch a movie. And in this movie, someone's smoking a cigarette or a cigar or whatever. And it's organized by the rating. And what you can see is there's actually been an increase lately in tobacco impressions in theaters, and it's in PG-13 movies, not in R-rated movies. And I think that is somewhat cause for concern that there has been an increase in in-theater impressions of tobacco use in PG-13 movies. Okay, so generally today in America, 14% of people smoke cigarettes, and that's similar to Minnesota. And I'm going to dive into this statistic, but most of them want to quit, which is a really interesting statistic to me. Most people want to quit. In fact, more than 50% of people tried to quit every year. Almost none of them succeed. Less than 5% of people succeed when they quit, but also almost none of them get help. So here is, again, just to dispel the notion that people don't want to quit. Black is I don't want to quit and I've never tried. And gray is I'm not interested in quitting. But purple, green, and blue is I am interested in quitting. And this is the trend is going, more and more people are interested in quitting. So, and you add it all up in this study, greater than 75% of people are interested in quitting. And here's another very interesting study to me, looking at psychiatric patients in an outpatient setting with depression, psychiatric inpatients, severely psychiatrically ill, and people in the methadone clinic. They want to quit too. 60% want to quit. So, and in this study, the methodology is different, so the percentages are different than the prior study I showed you. They want to quit just as much as the general population. So mentally ill and addicted individuals want to quit. And if you look at, if you ask people, have you ever smoked? And then if they say, yeah, I've smoked in my life. And then you ask them, well, have you quit? And actually an incredible number of people walking around out there have smoked and quit. So even though the quit rate, unassisted quit rate is 3.5% a year, with assistance, people can quit at about 10 to 15% a year. That feels really low, but year after year after year, it builds up. And a lot of people, 50%, 60%, eventually quit. And it could be even more. So there is a lot of hope. We're just not getting them the help to quit. And this is what happens to your lung cancer risk if you quit, depending on the age you quit. So if never smoked, lung cancer is very low. But smoked your entire life, your lung cancer risk is 16%. But you can quit at different ages and really, really affect your risk of getting lung cancer. So it's a powerful effect. And here's some other stats on to that degree. You know, if you quit before you're 40, your smoking-related mortality goes down by 90%. You basically only get 10% of the mortality risk if you quit by the age of 40. If you quit by the age of 55, you can add 6 to 10 years to your life if you quit by the age of 55. If you have a heart attack and then you quit, it improves your 2-year mortality by 36%. If you have lung cancer, you already have lung cancer, and you quit smoking, it improves the risk that the lung cancer will recur, and it improves your mortality. There's just like crazy statistics on smoking cessation. So kind of to summarize up until this point, most tobacco users do want to quit, but they don't get help. The biggest thing you can do to motivate them is to raise the cost of cigarettes, but also public awareness campaigns and offering them help will also help them quit. And anything that makes it less easy or less acceptable to quit, to use cigarettes will increase quit rates. And needless to say, quitting at basically any time prolongs and improves lives. Okay. Oof. So that's a lot. So, I mean, I can take a couple, if there's any questions, I can take a couple questions now, or I'll get into the neurobiology of nicotine, and then we'll talk about medications. So, Kurt, do you want me to drive forward, or does someone want to ask a question now?
Yeah. Any other questions? One quick thought, I had a guy once who said to me, he'd had a huge problem with cocaine, was in treatment, and he said that it was harder to stop smoking than it stop cocaine. And I think that kind of puts it in perspective, is that it's really hard to stop. But these are conversations. I literally just had one right before I came in here on somebody who wanted to stop smoking. And she's already stopped alcohol, kratom, marijuana, all these other things, and cigarettes are left. Is that a common, it's the last man standing, if you will?
Yeah, I want to address a couple aspects of that, and then I'll give some tips on how to help people quit. But, and you saying this made me think I'm going to add another slide. Not like there isn't enough slides already, which looks at all the drugs and rates their addictiveness. And tobacco is the #1 most addictive drug, and it's just beats out smoked methamphetamines and smoked cocaine. Those are like second place, smoked stimulants, but tobacco is the #1 most addictive drug.
Charlie, is that related to some of the data that showed like which drug, if you use once, you're going to continue to use?
Oh, that's separate data. I should look that up as well. That's out of Johns Hopkins or Baltimore. That's good. That's another great. Yeah, we'll talk about how quickly it develops addiction. I'll talk about that later.
Okay.
Any other? There's a couple in the chat, I might say.
Yeah, there was a little said. I had a patient tell me the same about quitting fentanyl and smoking. Yeah. So
I'll keep going. Save the questions up for later. So nicotine activates the nicotinic acetylcholine receptor, which is everywhere in the brain. I know we talk about all these like neurotransmitters, dopamine, serotonin, all these things. The brain is basically a computer with positive and negative signals. Like 99% of the brain is acetylcholine positive, GABA negative. And so it's positive and negatives. It's like binary code. It's on-off switches. Then there's like the dopamine and the serotonin and those other things and the endocannabinoids. That's like 1%, right? The vast majority of the brain is positive, negatives. And nicotinic acetylcholine receptors are just widespread in the brain. So of importance to us, it causes glutamate and dopamine release in the nucleus accumbens and gives you a sense of reward and salience. And I'll talk about those later. It feels good. It feels good. And it releases GABA in the amygdala, which is the emotional center, so it chills you out. So if you just think about it in that way, it makes you feel good and it lowers your anxiety. You say no more. You know why people love nicotine, but I am gonna say some more. Of course, I'm gonna say more. I always have more to say.
Charlie,
and then there's go ahead,
Charlie. I feel like you're trying to talk me into starting.
Yeah. Well, wait until you see this slide. So, acute nicotine ingestion has all of these effects. Acute, you're not tolerant. This is the first time you used it. Pleasure. Imagine you're a 15-year-old, or maybe you don't just remember when you were a 15-year-old and you popped a cigarette. Pleasure. Appetite suppression, arousal, not meaning sexual arousal, but just alertness, like you're arousing your brain, waking up. Appetite suppression, cognitive enhancement, memory enhancement, learning. Acute nicotine ingestion improves learning. It's not a sustainable effect, but acutely it improves memory and learning. Mood modulation, reduced anxiety. A pleasure. Okay, down here on this list, you're also going to get muscle relaxation. So people will classically, they'll defecate after having a cigarette, right? They'll muscle relaxation, vasoconstriction, hypertension, and increased blood pressure. So you do get some blood vascular issues, and some people will get nausea as well. So, boy, if you're a 15-year-old, this is like, other than you might get nausea at first and it makes you poop. This is like a wonder drug. This is everything you want as a 15-year-old. And we're not going to go into detail on this, but the nucleus accumbens is the reward center. It's connected to the ventral tegmental area, the VTA. And these are all the different drug inputs, whether it's PCP or alcohol or opiates or cannabis or stimulants. Anyways, this just describes that nicotine's in this mix, right? Nicotine, in fact, multiple different pathways leads to activation of the nucleus accumbens, and there's already including nicotine activates through the opioid receptors, and there is a relationship between nicotine and opioids not fully understood, but nicotine activates through the opioid receptors. Nicotine activates powerfully through the dopamine receptors, and then indirectly, nicotine also activates through the GABA receptors. So nicotine has many inputs to the reward center and is right side by side with all these other drugs that are doing the same thing. I think you should think of tobacco use early on as being a hard drug, right? We get so used to the person who's been smoking a pack a day for 20 years. I'll talk about them. It's not a hard drug for them. It's a poison, but it's not a hard drug for them. But for the adolescent who's trying tobacco for the first time, consider it a hard drug. Consider it like using cocaine. And I'm not exaggerating. I really believe one should consider early tobacco use to be as powerful of a drug as cocaine or methamphetamines, truly. And so, but what happens if you keep using tobacco is that very quickly, it's very pleasurable. So you learn to love it, and you learn to love everything about it. It reinforces its cues. And then very quickly, you desensitize to it. You rapid tolerance to nicotine, and then you start going into withdrawal. And I'll explain this more in detail. You rapidly, this is one of the characteristics of nicotine that makes it different from most other drugs. You rapidly desensitize. It's called neuromodulation. You rapidly experience neuromodulation, and then you have something called misattribution, and it's a real messes with your brain, and you don't understand what you're own experiencing. And I'll explain this in more details. But here's the moral of the story. If you get someone to smoke 100 cigarettes, there is a 70% chance they'll develop a tobacco habit. And that is why people go to bars on campus, college campuses, and hand out packs of cigarettes. They you just need to smoke 5 packs of cigarettes, and there's a 70% chance you'll smoke 5,000 packs of cigarettes. So, it does not take much to get you dependent on cigarettes. This neuromodulation from basically a very pleasurable hard drug to a ball and chain happens in 100 cigarettes. Okay. So, and this is a famous graph. Kurt and I think Heather have been running in treadmills at national meetings next to the author of this graph. This is by the one and only
Nora Volkow.
Nora Volkow. It's her world, and we're just living in it. She's serving dinner and we're eating. I don't know what analogy you want to use. She described, this is true for all drugs, but this is accelerated and extra true for tobacco. And what happens is early on, let's say you're that 15-year-old puffing a cigarette for the first time, it's intoxication and binge. It's delight. It's so much fun. Down here, it's all in the left-hand column. You're feeling euphoric. You're looking forward. You might have a little reduced energy when you're done with cigarettes. It's not terrible. You're feeling euphoric. You're loving it. You're looking forward to your next cigarette, and you're still in the voluntary phase of addiction. It's binging. It's intoxicating. It's delightful. I want more of that. This is awesome. They told me cigarettes were bad for me. I'm having a blast, right? Then pretty quickly you start neuromodulating, and you start having withdrawal and a negative affect. And that you'll still feel good when you use it. Now you're getting less and less excitement from it because you're getting more tolerant to it. And instead of looking forward to your next use, you're starting to desire the drug. It's maybe a craving, but it's a mild craving. And then you're also starting to have some behavioral changes that are concerning, like using at the wrong time, you're starting to break rules, you're starting to it's starting to intrude on your life. And then you keep using and you become preoccupied and have anticipation. And at that point, you're pretty well modulated towards the presence of the drug. You're not using to feel euphoric. You are using to escape dysphoria. That is neuromodulation. That is really critical. You're escaping dysphoria. So the using the drug so much has changed your brain so that when you're just resting state, you're dysphoric. And now you need the drug to just escape the dysphoria. And then you start feeling depressed and having mood issues, and you start obsessing over the drug. And at that point, you may have impulsive action. And you start losing control, obsession and impulsion, compulsion and impulsion, and obsessive actions. You start losing control of your actions. And this is all mediated through the rapid neuroadaptation, neuromodulation of your brain after exposure to nicotine. It's accelerated with nicotine, but it happens with other drugs as well. And I'm going to skip this because just for the purposes of time, I talked you through a lot of it. So what is misattribution? Misattribution is so important in addiction. It happens in cannabis, alcohol, opioids, and big time in nicotine. And what it is as you use nicotine, instead of it making you feel good, you use nicotine, your reward system, many systems in your brain downregulate. And now your resting normal state is feeling irritable, anxious, depressed, can't sleep, and can't concentrate. You feel like garbage. And that is because you exposed yourself to nicotine. It has changed your brain. But then when you puff nicotine, you feel better because you have replaced this nicotine and you normalize. And the misattribution is you think, nicotine helps me, right? Nicotine helps me. I feel better when I smoke. But the problem is, it's the reason you neuromodulated downward. So it's actually the reason you feel like dog crap is that you exposed yourself to nicotine, but you take a little puff and you feel better. And so you keep misattributing, the misattribution is you think it's helping you. And you probably, all of you have heard that with opioids. Opioids helps my pain. Well, yeah, 30 minutes after you snort your oxycodone, your pain goes away. But the reason you're in terrible chronic pain is because you're exposing to opioids too high of a dose. But we now accept that. The reason your pain is so bad is because you've neuromodulated in response to opioids. Cannabis, I don't know. There's a bunch of them with cannabis. Cannabis helps me relax. But we know cannabis exposure increases anxiety over time. Same thing with alcohol. Alcohol helps me sleep. They drink themselves to sleep, but they didn't used to have this much of a sleeping problem before they were drinking this heavily. So this misattribution is all over the place in addiction, but boy, it happens quickly and powerfully with nicotine. And it's very hard to convince these folks sometimes that nicotine is what's causing all these problems. And relieving it is just this illusion you're chasing. Anyways, if you can get someone to quit smoking nicotine or ingesting nicotine, the good news is a lot of the neuromodulation corrects within a month. So it's not going to be in a week or two, but in a month, a lot of this actually corrects. And a lot of the neuromodulation, they'll stop thinking that the nicotine is the only solution to their problem, and they'll just regulate. So on the point of psychiatric symptoms, anxiety and depression, there is a myth that if you quit smoking, it'll make you stressed out, or that I can't deal with this right now. I'm too anxious to quit smoking. Well, this has been studied repeatedly, and it is false. Every parameter of mental health improves after you quit smoking. All of these are statistically significant, and the benefit is like a 30% improvement in your anxiety, a 25% improvement in your depression, a 20% improvement in your quality of life, like a 50% improvement in your outlook, your positive outlook on life, and a reduction in stress by 20%, 25%. And this is true for people with psychiatric illnesses and without psychiatric illnesses. So quit having stress in your life is not actually a reason to continue to smoke. It's a reason people use, but you can reassure them that actually they can quit. Wow. They can quit even though they're stressed out, and it will actually improve things. And there's a complex relationship between mental illness and smoking. People with depression are more likely to smoke. People who smoke are more likely to get depressed. Someone who's smoking, their depression gets worse. Someone who's depressed, their smoking gets more intense. So it goes back and forth. You can treat them both together simultaneously. I need a better slide on this, so I had to look up the data on this, but schizophrenia is an intense case in point about tobacco. I'm not going to dwell on this because I want to get to the rest of the talk, but people with schizophrenia smoke a lot. Like that's the 4-pack-a-day smoker, the 3-pack-a-day smoker, the yellow fingers, right? They have a beard and their beard is yellow. A lot of them have psychotic symptoms, and there's a lot of theories of why they're smoking so heavily. We can treat them too. So with schizophrenia and tobacco use, you do take a harm reduction approach. They're probably not going to quit right away. The nicotine may actually be improving their hallucinations. So they're not going to quit because it's helping their psychosis. The nicotine is, or at least that's the theory. But you can have them reduce tobacco use as you start treatments, and they do sometimes quit over time, but they don't quit like normal people. You got to use harm reduction, and you got to stick with them, and you got to keep giving them nicotine replacement even though they're smoking. And they do eventually quit, but it's not on the same pathway as someone without schizophrenia. So an addiction, and just like with depression, tobacco and addiction, tobacco and other addictions are bedfellows. And we know this, we see this all the time. Opioids and tobacco are particularly cozy. So those, it's not totally clear why, but it's really common for opioid users. And there is that shared pathway in the brain near the nucleus accumbens that nicotine stimulates endorphin release. So it may be due to their shared pathway. I'm just speculating. You can quit smoking at the same time you quit other drugs. There's no quitting another drug is not a reason to continue smoking. But many of our patients choose to do that, but it doesn't need to be. So I'm going to go on to a little more direct advice on how to help patients quit smoking. And the first one is another principle of addiction, and it's about intensity of drug use. So you probably heard packs per day, PPD, packs per day. How many packs per day? And that relates to pack years. How many pack years have you smoked? And cigarettes per day, CPD. So we ask these questions, how many cigarettes do you smoke per day? Like it's a perfect science, but it's not. So, but I'll just give you the generals. If you want to know what a person ingests per cigarette, it's about 2 milligrams of nicotine. And I'll come back to that later. Each cigarette delivers about 2 milligrams of nicotine. But there are some people who smoke that cigarette for everything it's worth. They inhale deeply, hold it in as long as they can. Some of them will inhale deeply and douse the cigarette right away because they don't want to hold a burning cigarette because they waste tobacco. And they smoke it down to the very bottom. Whereas other people are very casual about cigarettes. They let it burn, they take a puff, maybe they put it out when there's 10 to 15% of the cigarettes not even smoked yet. So different people smoke cigarettes with different levels of intensity. people with schizophrenia smoke very intensely, obviously. So if someone says they're cutting down on the number of cigarettes per day, they might be cutting down on the number of cigarettes per day, but compensating by smoking those cigarettes more intensely. So it is known that you can't guarantee less tobacco exposure until they have reduced their cigarettes per day by half. So if I went from 20 cigarettes a day to 15 cigarettes a day, I could be even ingesting more tobacco if I wanted to. I'm just doing it in a more focused, intense fashion. So a lot of this happens subconsciously. So it's important to talk to your patients about the intensity of their smoking. It's also important when someone goes from 20 cigarettes a day to 18 cigarettes a day, take it with a grain of salt. But if they go with 20 cigarettes a day to 5 cigarettes a day, yeah, they are definitely reducing their tobacco intake. So intensity, that same sort of subconscious behavior happens with all drugs. So people will subconsciously moderate, the brain wants to be in homeostasis, even if it's unhealthy. So the brain is used to getting a certain amount of drug in per day. Try it with caffeine, try it with whatever else. Lower your risk. And your brain has a sneaky way of working around. Try to eat less. Anyone who's ever tried to lose weight, like me right now, just your brain has a sneaky way of undermining your best efforts. And it definitely happens with tobacco. So intensity of cigarette use is a huge thing. This is a validated tool to measure intensity of cigarette use other than just asking how many cigarettes per day. So I'll send these slides so you can look at this later, but this is a standardized tool used in pediatrics as well. Historically, tobacco use has been like a habit. It's habitual. It's about your circumstance. Oh, you're stressed out, smoke a cigarette. It is not. Tobacco use is very, very intensely pharmacologic. And I've been talking about that, but I'm going to give you an illustration. This is cigarettes, and no, cigarettes is the black line, and oral snuff is the dotted line. And these are all the nicotine replacement medications. So it's this abrupt peak in nicotine delivery to the brain. It's like you puff a cigarette and boom, it's in your brain. That is the key, right? This down here, which is what the nicotine patch does not cause an addiction. It doesn't give you that spike of blood to your brain. So the key is drugs that deliver the spike will create an addiction. Drugs that are just kind of low-level plateauing, don't do it. And what happens when you get this spike of nicotine is anything happening at this time becomes imbued with meaning. So you take the deep drag of cigarettes, you're holding a coffee cup, that coffee becomes magical to you, right? You take a deep drag of a cigarette, you're driving in a car, listening to the radio, listening to the talk show in the morning, your car and that talk show's host's voice is going to mean more to you because you just got this spike of nicotine in your brain. You take, you're sitting with someone, maybe they're not your work buddy, you go out on break. You might not even like this person, but you go out on break, you smoke a cigarette with them, and you feel a certain kinship with this individual you're sitting next to, even though if you think about it, you don't really even like the guy, right? So whatever you're doing when you get this delivered to your brain feels good. This does not have that effect. So salience is when something in your environment gets that special significance. The work buddy you smoke with, the car you sit in when you smoke your cigarette, your cup of coffee in the morning, whatever it is. If you want to help someone quit, you got to get them to understand their triggers. And everybody's different, but some things are really common. So what's common? There's cigarettes and the pack of cigarettes, that is going to be a trigger. Lighters are triggers. Ashtrays are triggers. By definition, these things are in your face when you're smoking a cigarette. Wherever you smoke cigarettes, and surprisingly, a car is a common spot these days. Wherever you smoke cigarettes, whoever you smoke cigarettes with, And anything you do when you're smoking a cigarette, and I'll tell you, a huge one these days is your computer. People sit by the computer, 2 hours go by, and they've smoked 10 cigarettes, and it's like very blissful for them. But if they sit in front of their computer, they want a cigarette. For some people, it's TV. For some people, it's, whatever. So what are you doing? So you got to get them to extinguish their triggers. They just can't, they have to make their car non-smoking. They might need to avoid that person on their breaks at work. Go for a walk on your break at work if you want to quit smoking. If you think you're going to sit out there with that guy and not smoke, forget about it. You're going to smoke. So you got to break the habit, and it will take at least a month to extinguish the trigger, maybe more. So we should be asking everyone, for the purposes of time, I'm going to not dwell on this. The 5 A's is what everybody's telling clinicians to do on every visit if possible. Ask about tobacco, advise to quit, assess readiness, assist in quitting, and arrange follow-ups. We should all be doing that basically every time for everyone who smokes. And we talked about most of this. If they want help, what type of tobacco do they use? How much do they use? Why do they want to quit? What are barriers to quitting? And then triggers, prior quit attempts, prior medication use. This is a little counterintuitive, but if someone tells you they want to quit, you basically want them to pick a quit date, cold turkey, within a week. If they plan a quit date beyond a week, it ain't going to happen, right? So you want a quit date within 7 days. That is the optimum, okay? If they say, now I want to taper, tapering cigarettes is inferior to a quit date cold turkey in 7 days. But it's better than nothing. Start the taper within 7 days. A 3-week taper. It's an inferior outcome, but don't let them talk you into a forever taper. It's a 3-week taper that you start soon. And the best is just quit within a week. And then especially people with schizophrenia, they're going to keep smoking. They are. So you prescribe them nicotine patches, tell them to keep smoking on top of the nicotine patches and come back in a month. And then you got to do all this stuff with the triggers we already talked about. Either motivational interviewing or a brief intervention are appropriate in addition to what I'm saying, but I won't belabor that. You can refer to CBT. Psychologists can sometimes do this themselves, whether CBT or motivational interviewing. There's a number of services that will text you and call you and encourage you and email you, and some people love this stuff. So the free services. We offer these types of things less to Black people. And the Native Americans not even reported here, but the disparity in tobacco harms is almost entirely accounted for by the fact that we give treatment and counseling less to Black people. So we got to give Black people treatment and counseling. We got to give white people treatment and counseling more. Everybody should be 100% maxed out on this. Everybody. And so here's again some rates of what percent of people were offered medications based on their, ethnicity or race. And we do best with white people, but all categories need improvement, and especially people of color. So everybody gets behavioral counseling, and behavioral counseling gets you 75% of the way there. It is the most important thing in quitting tobacco is counseling. And it's dose dependent. The more counseling, the more visits, the better results they get. So this is dose dependent based on minutes with you. Minutes with you talking about tobacco improves outcomes. And the more minutes you give them, the better outcome you get. And that's 75% of your outcome. 25% of your outcome is medications. And these are the medications. And I'm just going to quickly go through these. Hopefully I'll be done on time. Sorry, I got a million things to say, obviously. The commonest issue with nicotine replacement is we don't give enough. Each cigarette is 2 milligrams. So the strongest patch is 21 milligrams. The strongest patch equals a half a pack of cigarettes a day. And if you're smoking 2 packs of cigarettes a day, it's no wonder the strongest patch does not work. So you need to add lozenges or gum, PRN, on top of the strongest patch. Otherwise, it just isn't going to work. So the commonest problem with nicotine replacement is we underdose it. I'm going to leave it at that. That's a huge take-home point. You do not need to taper them over a month. They can be on nicotine replacement for the rest of their life if they want to. It is not going to harm them. With a few exceptions I'll talk about, it's totally safe. So I would say minimum 3 months, ideally 6 months, and indefinite if that's what the patient wants. If you take them off the patch and they go back to smoking, just leave them on the patch. No big deal. These are quit rates for Chantix in the pink, and then bupropion, Wellbutrin, in the blue. The patch only with no PRN is in the green, and then placebo is in the purple. So you can see Chantix is the winner, but I will tell you other studies show that if you add a gum or a lozenge on top of the patch, it boosts that green bar up, so it's getting close to the varenicline, the Chantix. But Chantix is the winner, clearly. And so you probably want to start Chantix. If you choose anything, I would choose Chantix. And this is true whether you have psychiatric or non-psychiatric populations. I'm not going to go into all the contraindications. That's a talk for another day. Chantix is number 1, but you have to adjust for kidney disease and caution in pregnancy. Bupropion can always be added on top of anything else or on its own, but there's a lot of things to know about bupropion and contraindications, so be careful there. I'm going to go through these. These are just references for later. And then I'm going to hit some special populations I think are really interesting. One, nicotine itself, and especially tobacco, worsens surgical outcomes. And if you want to have a good surgical outcome, you need to quit at least 4 weeks, probably honestly 8 weeks before your surgery, if you want to get the best outcome. And children of parents who smoke in front of their children have problems with their airway when they get intubated, like significant. So smoking in front of your child has a lot of harms, including surgical risk. And these are smokers versus non-smokers, wound infection. Smokers versus non-smokers, any surgical complication, wound complication, and cardiac complication after surgery. And I don't mean non-smokers, I mean people who quit 6 to 8 weeks before the surgery. So these are smokers who quit 6 weeks before the surgery. They don't have nearly the bad outcomes. Children, if they're not smoking, but they're exposed to smoke, they get ear infections, respiratory infections, and asthma, surgical complications, and they can get cancer. And they may smoke themselves because they're exposed to tobacco. So we should not ever be smoking in front of children, never. And adolescents, there is evidence that you should counsel them to prevent, but there's honestly no good evidence about treating tobacco use in adolescents. So any adolescent who's using nicotine, first of all, it's vaping. It's vaping. That's what they're using, probably. You need to screen them for all the other things because they're going to have mental health, sleep, eating disorders, other substance disorders, especially THC. They're going to have other issues. Remember that adolescents have confidentiality about this issue. Do not tell the parents. And e-cigarettes are not harm reduction in adolescents, unlike other populations. This is not harm reduction in adolescents. They should not be smoking e-cigarettes or vaping or whatever. Whereas pregnant patients is a different story. USPSTF says only counsel don't give medicines to pregnant patients not safe for the pregnancy, USPSTF. But everybody does it, and other countries do it. So there's evidence is sparse, but it's basically accepted to give pharmacotherapy to pregnant women in addition to counseling. And first line would be nicotine replacement. Second line would be bupropion, and there's just not much data on varenicline Chantix, so most people are a little nervous about that one. Vaping has been studied in pregnancy and could be harm reduction. Unlike adolescents, vaping in pregnancy could potentially be used as harm reduction. And there's tons of, I won't go over all the effects, but smoking in pregnancy is one of the most known teratogens on the planet. This hurts the fetus. There's no doubt, and the mom. This hurts everyone. And nicotine itself affects the fetus, but nicotine replacement has never been shown to. It's better than them smoking. So if the only way they can quit is nicotine replacement, it might lower the birth size of the fetus, but it is way better than them smoking. Everyone who smokes should get a pneumonia vaccine, and there is recent changes in the low-dose CAT scan for cancer screening. So here's a cancer found on a low-dose CAT scan. Everyone who's 50 to 80 years old and has had 20-pack years of smoking should get an annual low-dose CAT scan screening for cancer. And you can stop if they've had 15 years of abstinence from cigarettes, or you can stop if they have a life-limiting illness from something else. I'm just going to say this about e-cigarettes because I want to take questions. E-cigarettes are constantly changing. They are more powerful, they're sexier, they're cooler, they're smoother than they've ever been. And they deliver a lot of that spike of nicotine. So they deliver an addictive delivery of nicotine, and there is a lot of debate, and whatever research you're looking at is already out of date because they're constantly changing these devices. So you got to be careful drawing any conclusions about e-cigarettes. There may be some populations where e-cigarettes are good harm reduction. They are clearly less poisonous than tobacco. But then there are some populations where e-cigarettes are just wrong. Children, adolescents, it's just wrong for an adolescent to be using e-cigarettes. So here's my summary statement. Tobacco is bad, help people quit. And if there's time, I'll take questions. Thank you very much.
Well, Charlie, I rarely say this after a talk, but that was terrifying. That was pretty scary, some of the addiction side of that whole thing. But there are a couple of questions here. Any idea of the effectiveness of family/partners on quitting, such as constantly telling them to quit and that smoking is bad for them versus being supportive in quitting?
Yes, thank you. So the headline news, single most important thing that a family member can do is to make the environment non-smoking. Everything else is peanuts after that. If the environment is non-smoking, if the home is non-smoking, meaning no ashtrays, no lighters, no cigarettes, and nobody smokes. And if that can happen, everything else is peanuts. And then we use our normal addiction common sense in counseling family members that you want to push them as hard as you can to get them to quit without losing your relationship or alienating them or being a total jerk. And I would just say that to a family member. Use your judgment. You're this person's loved one. You've got the relationship. You need to keep your relationship, but encourage, push as much as you think you can get away with, but make that home non-smoking. And that has to be like a hard and fast rule. That is where you're allowed to be a jerk. No, if you got to go outside, you're going outside to smoke, but that one's going to pay off if the home is non-smoking. So what else?
There was a question about which of the nicotine replacements would be the pregnancy go-to.
Yeah, great question. So my choice is to use the puffer, which is very mild. The puffer delivers the least nicotine. People call it an inhaler. It actually delivers very little nicotine. It's through the mouth. You don't inhale it into your lungs, and it's the mildest. So if I'm worried about nicotine's effect on placental blood flow, I'm going to go with low-dose nicotine, and that's the puffer. But honestly, what I do is I count the number of cigarettes they're on. I estimate the amount of nicotine exposure they get, and I'll use whatever they want as long as I'm not overdoing it. As someone with schizophrenia, I just blast them 2 patches plus lozenges. They need the nicotine. I'm not worried about them getting nicotine. With the pregnant patient, I worry about too much nicotine. So it doesn't really matter. Just don't overdo it on the dose.
one of the things, my dad quit smoking when he was 35, actually. But he's 83 now and says, the best thing ever still was a cigarette and a cold beer. And I'm just wondering, was there anything that you came across about if people don't stop drinking who have whether they stop smoking?
There's so many, literally every question you could ask about tobacco has been studied. I don't know a third of the answers, but that's a really important one. The standard protocol we have used in our tobacco clinic at Hennepin is to assess for other drugs. Nicotine and cannabis are the big ones, but to assess for other drugs, advise them that other drug use might interfere with their quit attempts. But if they want to continue, let them have a try. But where you intervene with alcohol is if the quit attempt is failing or struggling. And then the alcohol this used to be worse when you could smoke in bars, but the alcohol will probably be a trigger where they associate alcohol use with nicotine use, and they drink and they get a little loose and they're out partying and they're out with their girlfriends. Everyone goes out for a smoke, and that's when they go back to smoking. So the alcohol consumption is a very problematic for tobacco relapse and to interfere with quit attempts. Alcohol consumption, some patients really want to try to quit while continuing alcohol, and I humor them, but I always follow up on it, and it may become a problem. Cannabis, many cannabis users mix cannabis with tobacco, and that is an issue for them as well. And finding ways to continue cannabis while quitting tobacco can be challenging for them. So I'll encourage them, if they smoke, switch to an edible. I'll try to make moves like that to break that association with coffee. If you used to drink coffee, find some other beverage to deliver your caffeine other than coffee for now, to try to break this association. You've got a powerful association with coffee. So
yeah, a couple of things. Aaron had a little question. What do you want to just unmute and ask it, Aaron?
Sure. I just briefly looked online if there's anything new being done for infants in nicotine withdrawal, because it's awful for adults, so it's got to be awful for them too. So are there any medications that can be used for infants, or is it just kind of a monitor and roll?
Yeah, I mean, preparing for this talk, I talked to a NICU physician, and he said sometimes the worst withdrawal he sees is with nicotine withdrawal. He had a patient who was born to a 3-pack-a-day smoker, and he said this baby had to go to the NICU and looked as bad or worse than opioid withdrawal. So it is like a real deal, depending on the intensity of tobacco use during pregnancy. I'm not an expert on exactly what they do and how they grade the withdrawal and how they treat it. But I mean, you were right on. It's an issue, and it's like it can require NICU level care. So it's an issue.
Does it nicotine go in the breast milk?
I think it does. Yes, I think so. I gotta double check that.
I've actually, when I was delivering babies way back, I had a lady who stopped drinking caffeine at her delivery. And she called me about 3 days later, and this kid was absolutely screaming, and it was horrific. And I'm like, drink a couple of Diet Cokes and feed that baby. And it's amazing how well that worked. But obviously, we don't want to tell people to have a few cigarettes. And
I'm shocked you promoted Diet Cokes and you didn't promote your favorite drug of choice.
And I'm down to just 3 of those a day, Charlie. So I'm listening to this addiction talk very closely. Trust me. And I get those Diet Mountain Dews out of my system. So kind of had one other question, and I'm trying to remember what it was. I know we're a little bit over, but man, I'm not sure. Anybody else got any other questions that they want to ask?
I am so appreciative of this opportunity. This is like a test run of the talk. I'm very enthusiastic for it. It was really helpful to get this opportunity.
Yeah. Honestly, Charlie, great talk. That was just stunning. And actually, Abby Labounty asked whether or not they can have the slides to look at again. Is that okay?
100%.
Yeah. So if anybody wants them, just email Katie and they can send those to you.
Okay.
So, well, thanks you very much, Charlie. That was the best talks of the year. I'm
Yep.
going to look at cigarettes a whole different way. So
My pleasure. All right. Talk
Great.
to you later.
everybody have a good week.
Yeah.